Welcome to Oncology Data Advisor. Today I'm joined by our Editor-in-Chief, Dr. Rahul Banerjee, who is also currently serving as chair of i3 Health's online activity and fellows meeting series, leveraging BCMA-Directed Therapies for improved patient outcomes in relapsed refractory multiple myeloma. Since recording this activity, numerous updates have occurred in research for this field, including the recent expanded approvals of idecabtagene vicleucel and ciltacabtagene autoleucel. Today, Dr. Banerjee is sharing some more insight into these expanded approvals and how they affect the treatment landscape for patients with multiple myeloma. Dr. Banerjee, always a pleasure to speak with you.
Thank you, Kira. Thank you for listening in. Yeah, this is one of those whole depressed moments. I'm actually covering our inpatient service right now, but filming this to talk about how idecabtagene vicleucel or idecel, and ciltacabtagene autoleucel, and ciltacel is what I'll call them, are two BCMA-directed CAR T therapies for multiple myeloma, have been approved for earlier lines. Some nuances in terms of what drugs patients have to have been exposed to, but in general, ciltacel for 1 prior line, idecel for 2 prior lines. This is a seismic change in the field. I cannot understate the importance of that. Prior to this, both CAR T products, which were approved in the last 5 years, were only approved for patients who'd had 4 prior lines of therapy. Interestingly, the trials, the KarMMa and the CARTITUDE-1 trial, did 3 prior lines of therapy. However, the approval was for 4 prior lines of therapy, and that was tricky. There was a couple of studies showing that only a minority of patients would actually become eligible for these particular therapies. And there was another study showing that for patients who were on the wait list, for example, especially early on, patients were more likely to die than they were to actually get CAR T therapy, partly because when someone gets to 4 prior lines of therapy, it's a tricky spot to be in. Their disease often is more aggressive, more difficult to manage. They often have more side effects from the previous therapies that they've been on. And so to kind of keep them going, because remember that CAR T is typically about a 2 to 3 month footprint of a patient's life that's taken up for the collection, the manufacturing period with bridging in between, the actual CAR T infusion, and then the actual monitoring period thereafter. And it's often hard to maintain disease control during those times for these patients. What I also found was happening, and I was very guilty of this, I would argue doing the right thing for my patients, but a little bit odd, would being that, look, honestly, 4th line therapy did not work that well in myeloma. So as soon as someone got to 3 prior lines, we're just kind of checking off a box saying, what can we call a 4th line of therapy, just to, check off this box, get them onto the on-label indication for this therapy. And it didn't quite make sense, especially because physicians like myself, we don't really think with lines of therapy, because lines of therapy are confusing to count and very nuanced in terms of what is a line of therapy, what's a change in an existing line, what's a new line, etc. These new approvals put that kind of decision-making to move CAR T into earlier lines into our hands. So, I'm not saying that everybody needs CAR T as 2nd or 3rd line therapy. Actually, as I'll get to, I would say the reverse. I would not say that. But there are some patients who absolutely need CAR T in 2nd line, 3rd line therapy. And I'm glad that that's now something that's within my jurisdiction to discuss with the patients. That here are your options with conventional therapies, CAR T therapy, and so forth. I think that's remarkable. There are patients who are definitely, stand to lose or stood to lose with the previous CAR T approvals, typically patients with functional high-risk disease, so early relapse after the 1st line of therapy, patients who, had very limited treatment options, refractory disease to their prior lines of therapy, and so forth. Those are the patients where getting them to 4 prior lines was very difficult. Now I have CAR T as a tool to use for them earlier. People have asked me, patients, physicians, even my colleagues, and does this mean that everybody should be getting CAR T as 2nd line therapy? The answer is clearly no. I can think of 3 distinct reasons why that might be the case. One, standard therapies do work very well for some of our patients. For example, the patient who's had, many years of remission after transplant, after frontline therapy, and is doing pretty well. I think a CD38 plus carfilzomib dex strategy, for example, like, ISA-KD, DARA-KD may work very well for them. 2, I think that CAR T therapy does have its side effects. It's not a totally benign treatment option. And so, better CAR T options are on the way. But, for some patients, they may be worried and say, look, I'm worried about this risk of cytopenias. I'm worried about what neurotoxicity might mean for me. I'm worried about these delayed rare toxicities, like, for example, Parkinsonism symptoms. And now there's a box warning about second malignancies that we discuss with our patients. And so CAR T is not for everybody in that regard. And thirdly, it's worth noting that CAR T therapy, as of now, still, even with these new approvals, that doesn't change where it's available. It's only available at large, high-volume centers, typically at academic centers. And so most of our patients don't live within easy driving distance of there. And so if a patient with indolent disease, biochemical relapse is trying to decide between, well, should I uproot my life and move to the big city for 3 months for CAR T therapy? Or should I just keep doing what I'm doing with my local oncologist, whom I know the best, and wait, and then at subsequent relapse, get the best CAR T therapy available in 2028? I'd say choose the latter. I think, do what makes the most sense for you. And so I think, these approvals are excellent because, again, they give us more options. However, it is neither the FDA nor any of us saying it's a requirement to do a CAR T, a second line or third line therapy, but it's an option. And for the appropriate patient, it's absolutely the right option for them.
Awesome. Well, thank you so much for coming on today to give us this really insightful perspective about the 2 new approvals. And to everyone listening, be sure to visit i3health.com to view Dr. Banerjee's full presentation on BCMA-directed therapies and claim free CME credit. Thanks again.